Hello, I'm Michelle Batty and I'm the manager of EUROGEN. EUROGEN is one of the 24 European reference networks created and funded by the European Commission since 2017. The networks cover most medical fields, and EUROGEN covers rare urorectogenital diseases and complex conditions. So they all need highly specialised surgery where the expertise is rare. And the aim of the network really is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urorectogenital diseases and complex conditions. So what are the activities of our ERN? Well, we conduct virtual consultations using a new tool provided to the ERNs by the European Commission called the Clinical Patient Management System. And this allows safe and secure cross-border case discussions. So I hope you saw the slides at the beginning, and we warmly encourage anyone who has a difficult case to please contact the network. We also conduct education and training activities like this webinar programme, and we write clinical guidelines together. And then finally, we also have a EUROGEN patient registry. So we're collecting all the information across our healthcare providers. And we're currently a network of 56 healthcare providers in 20 member states. Now, without further ado, the title of tonight's webinar is Long-Term Hypospadias Outcomes. And the first presenter is Professor Anne-Françoise Spinoit, and she's a paediatric urologist at Ghent University Hospital, Belgium. Due to my very naughty dog, I will give you the floor, Anne-Françoise.
Thank you very much, Michelle. And it's an honor to be here to present our long-term outcomes in hypospadias. I have the pleasure to do this today with my colleague, Lloyd Tack, who is a pediatric endocrinologist in our team in Ghent University Hospital. And Ghent University Hospital, where we both work, is actually a hospital which is a tertiary referral center for both urology and adult reconstructive surgery, especially in penile surgery. So hypospadias is definitely one of our most prominent, I would say, area of interest regarding clinical work, regarding research, regarding long-term outcomes, since it's really an area of interest over the last decade. And so if you want to visit us, please welcome. Ghent is a really nice city to visit. This is the team we work in. So as you see, it's not only urology and pediatrics. It's part of a DSD team also, and a huge team which encompasses people from psychology, from genetics, from gynecology, endocrinology, pathology. As you see here, all the people of the team as mentioned, and that's this cooperation that makes it so worthwhile and such an important topic of research. And so the background of this particular webinar is that, as many of you might be aware, is that in hypospadias there has been a shift over the last decade about the European and American recommendations. I mean, by that way that there are recent recommendations to defer some genital surgeries in some countries in Europe and North America. And defer until what age, and what is the influence based on that on the long-term outcomes? That's really an important question, because the current guidelines we have are based on the evidence from the last decades, which is based on early surgery. So many questions arise. As first, what is the long-term outcomes of early surgery? Well, we will be presenting data about that. But what we still don't know, it will be a question for the future, is what are the outcomes in case of delayed surgery? And so I hope to provide some answers about those questions. And first, I wanted to remind you of this publication, which is already 10 years ago, but it's at the back in the time, we still didn't have that many papers focusing on long-term outcomes in hypospadias. And so at the time, 2013, it was one of the largest studies published about long-term outcomes in hypospadias. I'm lucky and happy to say that since then there have been publications about long-term outcomes in hypospadias repair, so we know much more than back then. But still, there are so many questions that we don't know about those long-term outcomes. And so back then, it was for us important to see that in a large cohort of hypospadias patients, primary repair, we had quite good results without re-intervention in 75% of the patients. But 75% of the patients still mean that 25, so 1 out of 4 of those children required at some point in their follow-up, long-term follow-up required some re-intervention. So back then it was still quite new, especially since that in our series at least, 50% of those re-intervention were on the long run and not as it was described by them a few months or a few weeks after surgery, but most of those complications appeared then more than 1 year after surgery, which was back then quite new. And so this led us to the next study I want to highlight shortly, is that, okay, this is the long-term outcomes when primary surgery is done according to the guidelines, so at an early age, before the age of 2. But what happens when you defer surgery and when you operate at adult age? That was a question about our outcomes here in Ghent. And so this is a study which is not yet published, but it's going to be soon. That's a study where we looked at the long run outcomes of hypospadias operated after the age of 16. So after puberty, and they had surgery as adult, and we looked again as functional, aesthetic, and sexual outcomes. Important is that main age as surgery was 37 years, so definitely after puberty, and you have, as you see, long-term outcomes. In this study, including adult hypospadias repair, important is that on univariate and multivariate analysis, there were no prognostic factors identified for complications. But important is that only 36% of those patients operated at adult age were complications free. So I think that's really important to notice that those outcomes are really different. And if we compare the outcomes of those adult patients with the results we have in pediatric patients, we have, and this study is published 10 years ago, 75% of patients which are complications free. Well, in this study, in adult patients having primary hypospadias, only 36% are complication free. And when you look at the happiness with eventually reintervention, you see a really different level of happiness. So I think this raises a lot of questions that still need to be investigated and looking even more at different outcomes than just the complication rate. And that will be highlighted just in a few seconds by Lloyd Tack, who has done some tremendous work about those hypospadias patients. So my first short conclusions here is that, okay, we have some change of applications and some change of how do we deal with hypospadias. The importance of counseling will be really important. And do we really need to operate some of those hypospadias in the lands where we are still allowed to do this? Remember, less is more. So if the surgery is not necessary, those distal hypospadias in those with minimal complications, less is more. Sometimes waiting is better, but Lloyd will show you that in a few seconds. Thank you for your attention.
So, hi everyone, I'm Lloyd Tack. I'm a pediatric endocrinologist of Ghent University Hospital, Belgium. And I'm going to present a lot of my PhD project from a couple of years ago, and also some new data and hopefully some new ideas that we can discuss. So I have nothing special to disclose. And I'll be focusing on 3 studies that we published between 2021 and 2024, or something like that. So the main focus here was that we invited boys who had primary hypospadias surgery back when they were between 16 to 21 years old. So the young adults, adolescents, basically at the end of puberty, we wanted to see how they were doing. And we looked at psychosexual outcome. We also looked at their endocrine outcome, their fertility outcome, urological outcome, surgical outcome. And to try to see, you know, practice of the last 20 years, does it make sense, yes or no? We found a couple of things, but like many things in research, the more questions you answer, the more questions you get, and that's where I'll end here. So when it came to the psychosexual outcome, we saw some interesting things. We saw that these boys, they were quite happy that they had the surgery at a young age. So bear in mind that these were adolescents, young adults. A lot of them just said, "Oh yeah, I don't care," which isn't overtly negative. And there were actually very few cases. I think there was only 1 or 2 out of 200 that actually were negative towards it. What we saw was that those with a milder form of hypospadias and those who were dissatisfied about the end result, the aesthetic result, whether or not it was normal or abnormal, they had a more negative attitude. And when they were younger with the first surgery, they were actually more happy. So this is interesting. But what was really interesting to see was how the parents coped with this. And so we asked them at that time when their boys were were almost adults or young adults. How did they deal with the whole process of the diagnostics and the surgery? And a lot of them indicated that this was very stressful for them, and more in the complex hypospadias, which makes sense. But half of them still worried about their son's fertility, sexual experience, puberty, masculinity. So it's something that really left an impact on those parents, even though their boys were grown up or almost grown up. And we saw a correlation here. They were asked if they asked for the surgery themselves or whether the surgeon was the one to propose it. And we saw that there was less regret in those parents who indicated that they asked for it themselves. So this is really a call for shared decision making to really involve the parents in this process. And if they ask for it themselves, then the chances are higher that they will be happy and will have less regret when it comes to the surgery, or they have less doubt. And then psychosexual functioning, this was actually quite good. There have been a lot of studies looking at this. In our cohort, we didn't see anything different. We saw that those with severe forms of hypospadia and those with a lot of complications, they usually had a worse outcome. So the more genital surgeries and dissatisfaction with the genital appearance, they were correlated with less sexual functioning. But when we looked at the overall groups, it wasn't that different compared to our healthy controls. They were of the same age. I forgot to mention this. But so healthy peers, they're not 100% happy when it comes to their sexual life when we use those questionnaires, and there wasn't a big difference with the overall hypospadias group. They were less sexually active, those with hypospadias. They had a later age where they became sexually active. And we also saw quite a few boys, about 10% with erectile problems or ejaculatory problems. They were very diverse, so it wasn't that they all had anejaculation or late ejaculation, some had premature ejaculation, or it was a bit of a mix. And erectile dysfunction was also very mild, but it was still there for very young boys or young men. And then we also had a look at the surgical outcome. We saw a complication rate of about 40% of those who had their first surgery in university hospital. So we excluded here those who were referred for failed surgery from regional hospitals. So yeah, this is the experience of the university hospital in Ghent and as well as Vienna's. And this reflects a follow-up of about 16.5 years of follow-up, so after the first surgery. And we saw more complications if they had their first surgery before the age of 1, even when we excluded those with proximal hypospadias, because usually they have the surgery a bit younger, or they had the surgery a bit younger. Those with a smaller stretched penile length, or those with the severe hypospadias, they had more complications. Here you need to bear in mind, what's the cause? What is the result? Do they have more complications because the penile tissue is of worse quality, or do they have a smaller penis because they had more surgeries and this impeded the growth? It's something that we really don't know. And we also saw that if a specialized pediatric urology team, if it wasn't there, then we saw more complication. And this is actually based on the experience we had with Vienna. So we worked together with Professor Springer and his wonderful team in Vienna, where we also recruited boys. And those boys that were now in the adult age group, they had the surgery before they had the pediatric urology team. And then actually we saw that there was also a decline in the complications when they had their specialized team, and they had higher complications before that. So that's also quite interesting, that experience obviously is important, and also to have the specialized care will also improve your urological outcome in the long term. We asked them to do a Euroflow, quite a lot of suboptimal cases. A lot of these boys, they were really, they were happy, but they were unaware that they sometimes had dysfunctional voiding, but also, even if they had 2 streams of urine because they had a fistula. And bear in mind that almost 6% had a fistula present. They didn't really seem to care. They just put their finger on it, and they found it, or they thought that they had a normal urination or normal mixtion. And also 25% did not have the urethral opening, so the meatus urethra on the tip of the penis, but had still some form of residual hypospadias, and this also didn't really have an impact on their feeling regarding their genital appearance. So sexual dysfunction, I already mentioned this, but it's about 20% who have some mild problem, erectile or ejaculatory wise. And then interesting also to see, we compared the aesthetic outcome for what physician thought. So this was me or one of the senior urologists, compared to what the patient thought, and it's really not the same thing. And so the patient was actually more happy. For them, sometimes an abnormal appearance was their normal, and they didn't mind that much if they had some mild hypospadias or they had some scar tissue. Yeah, which is also quite interesting to see. Yeah, we put this in a nice graph to see which associations there were. If you're interested, this paper was published in the Journal of Urology, if I'm not mistaken, and you can see more details there. And then this is really my thing, and I hope you'll also be as enthusiastic as me when it comes to the endocrine and fertility outcome. So we had a look. We did morning blood sampling with everyone, so reliable androgen levels. We worked together with the andrology team in Copenhagen, Denmark, to really do in-depth analysis. And it was a bit surprising to see that all of these boys, they actually had a normal onset of puberty. They had a normal progression of puberty, even those with the very severe forms of hypospadias, with cryptorchidism and proximal hypospadias. We even had one with only half a testicle that was somewhere in the inguinal region. He went through puberty just fine, a bit low testosterone levels, but still quite okay. So it seems that nature really has a bit of overcapacity to compensate for problems here, definitely at a young age. And so we saw that the testosterone levels, they were not different when we compared them to their healthy peers. But we did see that LH levels were a bit higher. So this is an indication of a subclinical hypogonadism, so hypergonadotropic hypogonadism, but subclinical because testosterone is normal. And we also saw that insulin-like factor 3 was higher, and this is a very interesting hormone that's also produced by the Leydig cells, which does seem to indicate that there is a Leydig cell hyperplasia, but we don't have the biopsies to really prove this. But when we look at the hormones, it does paint a picture that testosterone production is okay, but it takes a bit more of the testicles and of the body to really produce the testosterone when you compare it to the peers. And then when we go to FSH levels and so the semen characteristics, it was also interesting. I was able to convince a lot of these boys to give a semen sample, even though they weren't really obligated to do it to participate in the study. So those older than 18, when you really explain them what the benefit would be and what the tests, what they needed to do, how things would go, then actually the vast majority of them were more than willing to give at least one semen sample. And actually quite a lot of them, or nearly all of them, gave the 2 samples with the necessary time in between the 2 semen samples. Azoospermia was quite rare. There were only a few cases. I think we detected one minor hypospadias with CFTR mutations, compound heterozygous, with bilateral absence of the vas deferens. But oligozoospermia was actually quite common. So when we compared the hypospadias group with controls, it was 18.5% versus 4% in the controls. And then we did a substratification. We looked at the different types of hypospadias. And those with the complex hypospadias were more at risk. And when we did this study, there were, I think, 2 or 3 studies available where they also looked at this. But more in the severe forms of hypospadias. So we know that in those with the proximal hypospadias or complex hypospadias are more at risk. But even those minor forms of hypospadias were twice as likely to have oligozoospermia compared to the control group. And then another thing which is I've heard from my colleagues and who are urologists, that birth weight and birth length is not of their interest, but when it comes to the testicles, it does have its importance. So as a pediatric endocrinologist, we look at the gestational age. So if the boy was born preterm or a bit post-term, we can really correct for that and calculate SD scores for birth weight and length, and then we follow the WHO criteria to see if they are born small for gestational age, appropriate for gestational age, or large for gestational age. And those born small for gestational age, so probably when there's a problem with the pregnancy, when they had intrauterine growth restriction or there was preeclampsia or something like that, these were the boys that actually had the worst semen quality and the lowest sperm concentration. So it was almost 60% of those who were born small for gestational age with any form of hypospadias, so even in the minor forms of hypospadias, who had oligozoospermia, so the really reduced sperm counts. And then we thought, okay, yeah, that's interesting, but do we really need to refer all of them for semen analysis, or can we do blood sampling and really predict it? And as it turns out, you have the FSH and inhibin B produced by the Sertoli cells, and FSH, the stimulation from the pituitary gland. If you would look at those levels, you would actually be surprised that they are good markers. They are good markers, and that's what you can see by those sensitivity and specificity analyses, that they do correlate with the semen quality, but when you would use laboratory thresholds, which are quite high for FSH and quite low for inhibin B, you would miss the vast majority of cases. So it appears to be a bit more subtle. But there is a correlation. But in the end, you know, if you have an FSH of 4, I don't think a lot of you will think that there might be a problem with the semen quality. It will still make sense to just refer the boy, definitely if they have questions and after counseling, to refer them to the andrology lab and really have a look at the semen quality under a microscope, because then you have definitive proof of what's going on. And then we had also genetics in this project, and I think this was a bit disappointing. So we, in the 100 most interesting cases, or about 169 or something like that, we did whole exome sequencing. We did a very big DSD, hypogonadotropic hypogonadism panel. We did also a POI genes, so premature ovarian failure. We included also the genes known for reduced semen quality, and in the end we didn't find any cases with a class 4 or class 5 variant, which means that there were no cases with pathogenic or likely pathogenic variants. We did have a list, and I've presented them here, of class 3 variants, so they might be associated with the phenotype, but it's not it's not that convincing. But we were very tough here, and then some geneticists that we talked about and then showed this this table. They say, yeah, you were a bit too tough. Some of them we might say that this is a class 4, but in the end, we do believe that when you do whole exome sequencing, even in the severe forms of hypospadias, even the familial forms of hypospadias, you're very likely to be disappointed, and you will not find anything. I'm not saying that you shouldn't do it, but it might be another discussion. In some cases, it might have a benefit to exclude, you know, WT1 mutations, which, yeah, you really don't want to miss, given the risk of the nephrological tumors. But to really use this in a research setting is the most likely way to use whole exome sequencing here. But yeah, I'm going to be brief here when it comes to the genetics, and then if you put everything together, and also with the small for gestational age, we do believe that genetics, they might play a role, and this would explain that there is about a 10% recurrence risk when you look father, son, or in brothers. So they do play a role, but probably epigenetics or environmental factors also play a role in the development of hypospadias. And this would also explain that the testicles, they do get a hit as well. And the thing that you might see from a clinical point of view is just the hypospadias. But the thing that happens during the pregnancy will probably also affect the testicles. But yeah, there's no definitive data on that, and there's no real consensus also internationally when it comes to that. We went also a bit further, and this is beyond my PhD era. We had a lot of the ultrasound data. So all of these boys, they had a testicular ultrasound, and we saw some microcalcifications, but not a lot of that. Not a lot of them had it, and on its own, it wasn't that much data to really paint a picture. And that's why we went back to the data. We also scored for homogeneity, so to see whether or not the parenchyma is homogeneous or not, and we also scored for that. And we also had a look. We included new cases here from childhood on, so the prepubertal cases and also some adults. And we found some interesting things here as well. So it's also always a bit tricky to really score ultrasound data. So we did it with three, a medical student, me, and Professor Spinoit. We scored for the microcalcifications and homogeneity, and turns out there's a good inter-observer variability. But the microcalcifications itself, we didn't see a large difference between our control group and the hypospadias group. But when we looked at the homogeneity of the testes, then there was a difference. And we saw actually more inhomogeneity in those with hypospadias compared to our controls. The study will hopefully be published soon. We're still working on the last things here. But when do you need to do an ultrasound in those boys with hypospadias, or when does it make sense? We saw that before the onset of puberty, and even before an advanced puberty, doesn't make a lot of sense. You will not see a lot, because obviously the testicles are quite small and you don't see that much going on in the parenchyma. But there were some interesting associations here as well. We saw in those with reduced semen qualities, they were more likely to have the inhomogeneity, but also those who had more penile surgeries, which I find is very, very interesting. There is no real data supporting my hypothesis, but I really think that if you have more complications, probably have poorer skin quality or tissue quality in the penis, and this will also be associated with problems in the testicles as well. Those with the shorter penis and adulthood will also have more abnormalities. Those born SGA, so small for gestational age, again have that association, and obviously the unhealthy lifestyle, but that has been reported in numerous studies before. And so, yeah, maybe to summarize, I presented a lot of data, and we can discuss it afterwards. So the psychosexual outcome in the hypospadias group, it's delicate, but it's not diminished. You need to do the surgery early, but not too early, and really be restrictive when it comes to the reintervention. So sometimes you just need to tolerate that there's a minor hypospadias left, or there is some scar tissue. As long as the boy can pee and the penis functions well, then actually you will actually do more good just waiting and providing follow-up for the boy. Psychological guidance for the parents and sometimes for the boys might be indicated. But bear in mind, a lot of them are really happy with the surgery. They're happy with what has happened. So I find this really strange that the governments, they want to restrict this. I think the boys of hypospadias are collateral damage with a bigger thing going on. But I don't think we need to discuss that here. The reintervention rate is really high. So yeah, lifelong follow-up is really recommended. 40% complication rate in a specialized team. This is a lot, and some of these complications really arose quite late. So even 20 years after the initial surgery, they could have their first indication for a reintervention. Urological outcome and sexual function is not awesome. 50% have some problems, so it's really again supports lifelong urological follow-up. But yeah, again, they are happy with how their penis looks. So really the aesthetics, they don't matter that much, and even for their partners it doesn't really matter that much as well. And when it comes to puberty, normal puberty is really is to be expected. Even in those severe cases, doesn't mean that we as a pediatric endocrinologist cannot play an important role. Definitely when it comes to growth, I excluded it here because I think none of you really care about how tall the boy will become, but those born small for gestational age, a lot of them, so 30%, will have problems growing and reaching their height potential. And then when it comes to the testicular function, there seems to be real association with hypospadias and testicular function. So hypogonadism, not overt in those young boys, but at an adult age, we don't know, like when they become 50, are these the ones that will have hypogonadism, something that we don't know. Also the fertility problems, they have, a lot of them have oligospermia, but if their partner is really fertile, doesn't really mean that there must be a problem. But yeah, how will this evolve when they turn 30? It's something that we're looking at, because study was a couple of years ago, so we can re-invite those boys. And don't fully rely on those hormone levels. So FSH and inhibin B, they are good markers, but it can sometimes be very subtle. And then yeah, the inhomogeneity, I just said it a couple of minutes ago. And so how do we want to proceed? Because yeah, we answered a couple of questions, but there are still a lot of questions left. And one of the things that we're interested in, and we have been interested in this for I think over a decade here in Ghent, and we have collaboration with a center in Germany with Kiel to have more advanced methods. We also published a study on the androgen receptor, looking at the foreskin samples, and I can obviously read this more in detail, but it turns out it's actually quite difficult to do. It's very difficult to look at the dartos tissue to see how it's developed, to really develop a scoring system. We developed a new scoring system for the androgen receptor on those samples, but a lot of them, they don't really have expression and of the androgen receptor, and the controls, they don't have this as well. So we don't really know, is this because there's a problem? Yes, no. You have the ApoD analysis and Kiel, which is very interesting to see if there's downstream signaling problem. But actually, everything has its limitations, and it's very, very tricky to look at histological material and to really compare groups without being biased, and also the more advanced genetic tests, epigenetic tests, they take a lot of time, they take a ton of money, and there's no real guarantee that you find something because it's probably multifactorial. So that's what we're working on. If there are people interested in collaborating, and you can obviously contact us. And so, the adult outcomes is also something we're looking at, and the role of prenatal factors, placenta, and stuff like that. It's quite interesting, and there's still a lot of gaps in the current knowledge. And so, that concludes my presentation. I hope we still have some time for questions. But I do have to thank everybody because we had a whole team to do these studies. I especially would like to thank our colleagues in Vienna, Professor Springer and his wonderful team. Who allowed me to work with them for a couple of months and to recruit the data, even with my shabby German. So that was great, and the University of Copenhagen, of Linz, and our team here in Ghent is all instrumental to allow us to do these studies, and it took a lot of money, so the funding agencies really helped us as well. So I'd be interested to answer your questions, and let me know what you think.
Okay, thank you. Thank you both presenters for those interesting presentations. So I'll just invite people now. We've got a few questions already have come in. So hopefully you can see those. I will just do those in a moment. So I'll invite everybody else. If you do want to ask a question, please do so now. We've got around 20 minutes to take some questions. Just a reminder to all the attendees that you will receive a link to a survey straight after the webinar is finished. You'll also receive the link via email as well. If you complete the survey within 2 weeks, you will get your accreditation certificate in about 2 to 3 weeks' time. Also, we'll be sending out the recording link for this on our YouTube channel tomorrow to all registrants. And if you have questions afterwards as well, if we don't get around to them today, if we have some we can't answer, we'll take them away with us and try and answer them offline. If you are watching this on recording, you can still put your question into the YouTube comments, for example, or email me. You'll have my details as well, and we'll pass on those questions. Okay, so I think we can move on to the questions. Hopefully, Lloyd and Françoise, you can see those.
Yes, thank you.
I'll leave you to.
Okay, so I see that we'll start maybe with the first one, which appeared a while ago. Comes from Iris van Rooij, and she says, what was the reason for the late surgery in study 2? So study 2 was the study I presented about primary hypospadias repair in adults. So it wasn't connected complications because it was all primary surgery. The reason for those primary surgery at such a late age was mainly first very distal hypospadias in men with new partners, or adults coming from other countries where they didn't were offered the chance to have a primary hypospadias repaired. We had a huge populations there of migrants, and that was the two main reasons the initial surgery was proposed after puberty and at such a late age. So nothing to do with complications, primary surgery, all of them. That's the first answer, I think. I see a second question that will be for you, Lloyd, I think, coming from Rianne Lammers from the Netherlands. And she asks, from the HERO study, did you include boys that got hormone stimulants as a child before their hypospadias correction? Well, I can help you also, Lloyd, by saying that in Ghent here, we never give basically hormone stimulants before surgery, before hypospadias repair. So that's not our daily practice. We never did that since I'm in Ghent and in those studies, basically. So we have no idea about the effects on those outcomes because we never use it.
Yeah. For this study, yeah, the majority of boys, they didn't get any testosterone or cystanol or DHT cream or something like that. Definitely those who came from Ghent. I think there might be a couple where we do tend to give it if they present with the micropenis, but not for the hypospadias. Sometimes we give it like in the Klinefelter or stuff like that according to the guidelines. But those boys were not included in the study. I think in Vienna, which was a large part of the cohort, the vast majority also did not get any testosterone treatment prior to the surgery. There might have been a couple, but there was too little data to really analyze that. So I cannot say anything about the effect of the treatment on the outcome of our patients, because if there were a couple, and I don't think that it's going to be more than 1 or 2%, then yeah.
I see the next questions coming from Cecile Kumar. Are your repairs anatomical or non-anatomical in terms of tissue approximations? I'm not completely sure what you mean with that. I mean, our techniques are the classical techniques. Most of our techniques are tierce du play in Ghent, which is quite anatomical repair. We don't use really often onlays, and if we do, it's usually in really proximal hypospadias where we do a two-stage where we will use the prepucial skin to lay the bed for the graft or for the flap. So I guess in most repairs are anatomical, if that was the point of the question. And I see still from the same persons, did patients older than 16 found ejaculation orgasm disturbed after repair compared to pre-repair? That's probably about study 16, maybe a part about you. And about my study, I don't know because it was a retrospective study and we didn't have preoperative questions. About the HERO study, Lloyd, well, we don't know because, I mean,
yeah. They all had their surgery early on. I think that there was only one who had it at 12, and the others were all toddlers or kindergartners at best. So we don't have any data the only thing that we do have is we have a cohort of peers with the same cultural background here from the Flemish region and from Vienna. So those peers, they reported mild erectile dysfunction in about similar proportion. The ejaculatory problems, they were not that common, but I don't know, before the surgery, yeah, they were too young, so yeah.
So we don't have the answer to these questions. There are really interesting questions, but I think we will need cooperation internationally and larger to have the answers. I see another question who would like to ask me if there is any difference between distal and proximal hypospadias cases in terms of early and late surgery. Well, in case of late surgery, we had match the patients, so we don't know. In your study, Lloyd, do you still hear me? Okay.
Yeah.
In your study, Lloyd, there were some differences between proximal and distal hypospadias, but it depends on which term of outcomes, right? And we didn't have your study were all early surgery. There was no late surgery. So again, this is a really interesting question, but we don't have the patient data to answer this question, because the only data we have about late surgery comes from our study, where we don't have the power to answer. We had too few patients with proximal surgery to really make difference.
Yeah, we for the HERO group, we looked at age at first surgery as well, and for the complication rate, and we did see that that's about the optimal age when we combine also the psychosexual outcome study would be around 1 to 1.5. So actually, according to the guidelines before 1, we did see more complications even when excluding those with proximal hypospadias, which might say something about the penile development or the penile size. But yeah, beyond that, we don't
But in
have.
your study, we didn't have any patient operated after puberty, right? So
No.
we don't know this part. So that's still an open question also. I mean, real interesting. I see another question from somebody anonymous who asks, what are the potential causes of persistent pain during urination ongoing many years? I'm not sure what they mean with this. I don't really have patients who complain about persistent pain during urination unless they have stenosis or other problems. So I'm not sure what you mean with that. If you would add something on the chat, I would be happy to answer it. And then I see a second question: fistula repair and dilation after same. Okay. I'm not sure here about this question. It could be more specific. It could be nice.
I think they're saying, they're describing their case. So they're saying they did repair age 2.
Oh, okay.
Sensation the same, and then describing what happened, I think. So
okay, sorry, I didn't get that.
yeah,
Now pain when you urinate. Well, I think maybe we could chat after the webinar and discuss this case. I don't immediately have a clue. I see another question. For hypospadias with small penis, do you give testosterone injection or local before surgery? Here in Ghent, we don't do it. So again, that's all the patients you have seen the results here. None of them in Ghent has ever received testosterone injection of cream of whatever before surgery, as it's not our practice. And in Vienna, some of them might have received it as said, but a very small number.
Yeah, there's also another study that we're working on in a collaboration with Vienna, and then with the proximal hypospadias at this time they tend to do it, but I don't think it makes a lot of difference when it comes to surgical outcomes. But we didn't compare obviously the proximal hypospadias outcomes from the boys here and there, because we recruited them during the surgery, but I think it's a lot about preference of the center and what you want to do.
Well, the rationale is that also if you give testosterone, the data shows us that you increase the gland size. And we know that the gland size is one of the prognostic factors for complication. What I mean with that is that data show that the smaller the gland size, the more likely you have to have dehiscence or fistula. And so the rationale is that if you increase the gland size thanks to testosterone, you might lower your chances of complications. Thing is that there are not so much data proving that there is no randomized controlled trial. There is no data out there showing us that the one is better than the other. We have cohorts from both, but we don't have match cohort. We don't have comparisons, so we don't know. And since usually if you're in center where you give testosterone, you will give it to all of them, or if you're a center where if you don't give testosterone, you won't give any of them. And those centers might not have the same practice for techniques. It's really difficult to compare because you will have a bias anyway. So I think we need data out there to be able to say anything. At this time, we don't know. I see another question. Do you have any thoughts about late complications, fistula, and why they appear late a lot? I would like to be able to answer this question. I really would like. If I had any thoughts about how the complications arise so late, I would do anything to avoid it. I think it's a complex mix about the growing tissue where there is a scar that might be not growing as the same rate of other tissue, with maybe appearing LUTs, with potty training, with adolescence, with other functions that come like ejaculation. I think there's a big mix there about many factors, and I think it's really difficult to know why in some patients it appears and why it doesn't appear in the other patients.
Mhm.
And if anybody can ever answer that, we will have the key on how to lower complications. So that would be my dream to know it, actually.
I would like to add something. When you see those late complications, I think some of them might have been there for quite a while, and that's what we taught in the HERO study as well, because those boys, they develop a coping mechanism. If they're starting to pee from two streams, they just put their finger on it. So we don't know if they had this for 5 years or longer. But I'm a real believer that there's something wrong with the tissue quality in general when it comes to the penile tissue. We see it in the foreskin samples. It's something hard to really prove. And we're working on that with different methods and different studies going on. But I'm guessing the entire genital skin and also the testicles, the penile tissue, they're all from a worse quality in a lot of those hypospadias cases, which will explain the high complication rate. And that's my point of view. But I am not a surgeon. A lot of things François says are Chinese for me. So, but yeah, from a simpler point of view, I think there's a real problem with the tissue quality, and there have been a lot of studies also from Glasgow, where from pediatric endocrinologist point of view, they also had had a look at the vasculature and did the functional tests in the vasculature in those boys with hypospadias, and they also saw that, that there are a lot of signs that the wound healing is impaired, and this is intrinsically impaired in those boys with hypospadias. I don't seem to recall if this was an epigenetic problem or this is more a functional problem of underdevelopment. But yeah, there is a lot of work going towards those complications. It seems to be a lot of things, and lower expression of the blood vessels, smaller blood vessels, but also I'm guessing that the androgens also play an important role in that tissue. So yeah, I hope that's also what you meant by that question. Yeah.
I don't see any more questions appearing. So
No more. So I just want to give people one more chance. If you have a question you do want to ask now, then please type it now. So just while we wait for that, I meant to remind people earlier that please check out our website to see what future webinars we've got coming up. Actually, we have another one next week on hypospadias as well. So I'm sure many people here will be interested in that as well. We'll be advertising that soon and sending out the registration link maybe tomorrow or Friday. Yes, a reminder again about the surveys. Please do complete those in 2 weeks. It helps us, and so you will enable you to get your accreditation. Okay, so I think we've just got people saying thank you again, so thank you for that. No other questions, so great. So thank you everybody for attending and for all your questions, and thank you most of all to our presenters tonight, to Lloyd and to Françoise. Thank you very much indeed, very interesting. Yes, I hope have you got anything you want to say to finish with, but thank you very much both for taking the time to do this. Okay, everybody, thank you very much. Have a good evening. Bye-bye.